1 in every 2 adults has heard those words at some point. You need surgery. But here's the part that should really concern you. Research indicates that somewhere between 10 and 20% of all surgeries carried out in the United States might actually be avoidable. For lower back procedures alone, studies have shown that more than half of lumbar spine operations are considered unjustified. We're talking about 2.4 million unnecessary surgeries every year. That's not just a minor oversight. It points to a much deeper problem in the system. And if you've ever been given a surgical referral without anyone suggesting a second opinion, without trying every non-invasive option first, or without anyone truly asking why this is happening, then this message is meant for you. The current healthcare setup makes more money when you end up on the operating table than when you walk out feeling truly well again. If you're new here, make sure to subscribe to Dr. Arthur Bennett and drop a like. We're working toward 1,000 subscribers, and what I'm about to share is something most fee-for-service practices have little financial incentive to tell you openly. Let me begin with the single most important idea in all of surgery, one that experienced surgeons understand deeply but don't always communicate clearly to patients. The best surgery is the one that never happens. That's not fear talking, it's not avoidance, it's genuine hard-won medical insight. The second a blade cuts into your body, there's no going back. The scar tissue your body creates to heal that wound stays with you. It's dense and fibrous, and it permanently changes how your body moves and functions. It can press on nearby tissues, limit blood flow, and alter mechanics in ways that last forever. That's exactly why any skilled surgeon should be asking one critical question before scheduling anything. Have we truly tried every possible non-surgical approach? Because once the knife is involved, that question can no longer be answered. Let's go through the 5 procedures I most frequently see performed without strong enough reasons, and what you should consider doing instead. The first is surgery for a herniated spinal disc. You show up with back pain, get an MRI, the report mentions a herniation, and suddenly a specialist is recommending an operation within days. But here's something they rarely explain during that visit. If you took 100 healthy people with no back pain at all and scanned their lower spines, about 50 of them would show a herniation or disc bulge. Half the population, most of them completely unaware. That means the picture on the scan isn't automatically the problem. It's just a finding. The real diagnosis only exists when someone's actual symptoms match that finding. And even then, surgery is seldom the first step. There is only one true surgical emergency with disc herniations, cauda equina syndrome. That's when the bundle of nerves at the base of the spinal cord gets severely compressed, leading to increasing leg weakness, loss of bowel or bladder control, or numbness in the saddle area. In that rare case, yes, you operate immediately, but the vast majority of cases involve ongoing low back pain and occasional sciatica, that shooting nerve pain down the leg. These usually improve with conservative care. Here's why it happens physiologically. Your spine is a column of bones separated by gel-like discs that act as shock absorbers, evenly distributing pressure. When everything is balanced, the disc stays in place. But if your pelvis is tilted, your deep core muscles are locked in spasm, or old injuries have thrown off your body's alignment, pressure becomes uneven. The disc gets squeezed on one side and pushes out on the other. That's the herniation. Now ask yourself this. If you simply cut out the bulge without fixing the uneven forces that caused it, what do you think happens next? Your body still needs cushioning, so it creates another bulge, often at the disc above or below. Within 2 or 3 years, many patients are looking at a new herniation on imaging. This isn't a surgical mistake. It's the expected result of fixing the symptom while ignoring the root mechanical issue. The real causes behind that imbalance include hip problems, pelvic rotation, where the pelvic bones shift out of alignment, tight, deep spinal muscles, lingering ligament strain from past injuries, old tailbone trauma, or even a whiplash incident that looked fine on X-rays but left hidden asymmetries. These unresolved issues slowly throw off the load distribution across your lower back, eventually turning into pain. What continues to amaze me in practice is how little the length of suffering seems to matter. I've worked with people who've dealt with back pain for 10, 20, even 30 years. When we properly realign the pelvis, release chronic muscle tension, and restore healthy movement patterns, the pain often disappears, sometimes in just a few sessions. Watching someone let go of decades of discomfort in a matter of weeks never loses its impact. The research supports this. A major study comparing surgery versus conservative treatment for lumbar disc herniation showed that surgery provided quicker relief at 6 weeks. However, by 1 year and 2 years later, the results were essentially the same between the two groups. Later reviews confirmed the same trend. Surgery helps faster in the beginning, but long-term pain and function levels even out. Meanwhile, the rate of needing a second surgery after a disectomy sits between 8 and 12%, meaning roughly 1 in 10 patients ends up back in the operating room. So before you say yes to spinal surgery, here's what to do. Seek out a skilled musculoskeletal expert who truly understands biomechanics, not just MRI images. Go through a complete conservative program that targets the mechanical root cause, not just the symptoms. Only if you start developing progressive weakness, worsening neurological issues, or changes in bowel or bladder function should surgery become a serious discussion. The second common procedure is hemorrhoid surgery. Hemorrhoids are basically enlarged veins in the anal and rectal area, like varicose veins of the lower gut, and they affect a huge number of people. Surgeons often move quickly toward an operation, especially if there's bleeding. And yes, surgery can be effective. Recent analysis shows it delivers higher rates of full symptom relief and lower short-term recurrence compared with non-surgical approaches. But here's what that analysis didn't cover. Something I want you to consider seriously. Let me share the story of one patient I worked with. A middle-aged man with active bleeding from hemorrhoids, looking noticeably pale from anemia even before his blood work came back. He had already been referred for surgery. He came to me because the idea of being laid up for a month, unable to work or be present for his family, felt unbearable. He told me, try whatever you can. On examination, I discovered significant visceroptosis. His abdominal organs had dropped lower than normal and were pressing directly into the pelvic area, putting constant pressure on the rectal veins. Blood couldn't flow upward properly, so it backed up, causing the veins to swell and eventually bleed. He also had an old tailbone injury that was restricting the natural subtle movement of the sacrum, the triangular bone at the base of the spine. That gentle motion normally helps with pelvic blood drainage. When it's blocked, congestion worsens. Additionally, there was restriction in the occipital bone at the base of the skull. Most people don't realize this, but the occipital bone and sacrum are connected through the dura mater, the tough membrane that lines the entire spinal canal. A restriction at one end affects mobility at the other, which can contribute to poor pelvic circulation. We addressed each layer, lifted the organs, restored movement to the occiput and sacrum. The bleeding resolved, and surgery was no longer needed. I'm not saying hemorrhoid surgery is never the right choice. In advanced cases, it clearly offers the best results according to the data. But I've seen enough situations where the mechanical factors were never even examined. If your surgeon schedules an operation without checking for organ descent, sacral mobility, or pelvic alignment issues, that evaluation is incomplete. And even when surgery eventually becomes necessary, fixing those underlying mechanical problems first can significantly improve results and lower the chance of the issue returning. This isn't about replacing surgery, it's about doing the right work before surgery. The third procedure is surgical correction of diastasis recti. This is the separation of the two vertical abdominal muscles along the midline connective tissue. It's especially common in women after pregnancy. When the gap reaches 6, 7, or 8 centimeters, many surgeons recommend stitching the edges back together. In my experience, though, many women who start a properly guided core rehabilitation program, focusing on deep stabilizers like the transverse abdominis and pelvic floor rather than crunches, see dramatic improvement. A 7-centimeter gap can reduce to 3 centimeters in just weeks without any surgery, scars, or long recovery periods. This makes sense because muscle is living tissue that adapts to the right mechanical signals. Proper loading, good pressure management inside the abdomen, and progressive strengthening allow the connective tissue to remodel and the muscles to move back toward the center. That's basic exercise physiology at work. Surgery, on the other hand, can pull the edges closer with stitches, but it doesn't restore muscle strength, neuromuscular control, or coordination. If the muscles stay weak, the separation can return. For women who need need to lift, carry, and move daily, that functional difference is huge. So if you're told your diastasis is bad enough for surgery, take a breath. Get evaluated by a pelvic floor physiotherapist or a specialist trained in diastasis rehab. Commit to the program for 2 to 3 months and remeasure. You might discover the surgery is no longer necessary. The fourth is vein surgery for varicose veins. This ties directly into the same mechanism we discussed with hemorrhoids, visceroptosis, where abdominal organs drop and press on pelvic veins. Think of the leg veins as a low-pressure system that relies on calf muscles and one-way valves to push blood upward against gravity. When descending organs compress the major pelvic veins, it's like putting pressure at the top of the thigh. Pressure builds below, valves start to fail, and veins stretch and bulge. Spider veins appear first as an early warning, followed by larger, twisted varicose veins. Pregnancy, long hours of standing, and chronic constipation all speed this up. Nutritional factors like low vitamin D or insufficient bioflavonoids can weaken vein walls further, as can inherited connective tissue differences. Modern treatments like laser ablation, sclerotherapy, or vein stripping can improve appearance. But if the underlying organ descent and pelvic pressure aren't addressed, new veins often develop within 2 to 3 years. Many patients tell me they've had the procedure multiple times only for the problem to return. The smarter path starts with correcting the organ position, easing pelvic pressure, fixing nutritional gaps, and strengthening support muscles. In early stages, this can halt progression completely. When surgery is still needed later, doing the mechanical work first means the results last longer. Often just one well-timed procedure instead of repeated ones. You can get a sense of whether organ descent is playing a role by standing relaxed in front of a mirror. If your lower abdomen protrudes, even when you're relatively lean, that's often a clue. This isn't just about looks. It can contribute to varicose veins, hemorrhoids, back pain, and bladder issues. These aren't separate problems. They're connected through the same anatomy. The fifth is surgical repair for pelvic organ prolapse, lifting and securing a descended uterus, bladder, or rectum. This is a major surgery, and by the time many women reach this point, the issue has been progressing for years. The problem develops from two directions: downward pressure from visceroptosis above, and weakened pelvic floor muscles and ligaments below, often from childbirth, chronic straining, or tissue changes. The organs slowly shift downward toward the vaginal opening. Because it happens gradually, many women adapt and don't notice until it becomes advanced. The good news is that at early and moderate stages, this often responds well to conservative care: pelvic floor physiotherapy, abdominal wall rehab, and gentle repositioning of the organs. I once treated a woman with first-degree prolapse. Through visceral work, pelvic floor strengthening, and abdominal rehabilitation, her symptoms improved greatly. But life got busy, she stopped the program, and 5 years later, the prolapse had worsened to the point where surgery became necessary. The surgery went well, but she had missed an earlier window where non-surgical care might have prevented it entirely. I share that not to judge, but to highlight how important timing is. An early-stage prolapse taken seriously is often a fixable mechanical issue. An advanced one that's been ignored usually requires surgery. The approach changes less than the stage at which you choose to act. Age starts to play a real role here too. After 50, the connective tissue changes that contribute to all 5 of these issues: disc wear, vein weakening, ligament looseness, and fascial thinning pick up speed. In women, declining estrogen after menopause affects pelvic floor strength and raises herniation risk. In men, core strength naturally declines and spinal loading patterns shift. These aren't just ideas, they're changes I observe regularly in practice. So tell me, how old are you? Drop your age in the comments. I want to know which age groups are here, because the advice for a 32-year-old with a recent disc issue is different from what I'd recommend to a 58-year-old with multi-level degeneration. Your feedback helps me create content that actually serves you better. Let me wrap this up with straightforward, practical steps, the same kind I'd give you face-to-face in the clinic. For disc herniation, don't agree to surgery based only on an MRI. It's only clearly justified when you have progressive neurological problems like increasing weakness or loss of bowel bladder control that don't improve with a solid, thorough conservative program, meaning months of proper biomechanical work, not just a handful of basic therapy sessions. For hemorrhoids, before heading to surgery, request a full mechanical assessment of your pelvic region, organ position, sacral movement, tailbone health. These are standard checks that should happen first. For diastasis recti, a large gap on measurement isn't an automatic ticket to the operating room. Work with a qualified pelvic floor physiotherapist for 2 to 3 months, then reassess. Many times the need for surgery simply goes away. For varicose veins, in early stages, focus on correcting the mechanical and nutritional factors. If surgery is still required later, make sure the underlying causes have been handled first so the results last. For pelvic organ prolapse, if it's caught early, don't wait. Start pelvic floor therapy and structural work right away. Acting at stage 1 can keep you from ever needing surgery. Waiting until stage 3 often removes that possibility. In all 5 situations, the key word is first. First, identify the mechanical cause. First, fully explore conservative options. First, rebuild a strong structural foundation. And only then, if surgery is truly the last remaining choice, go into it with everything optimized, better mechanics, healthier tissues, and the upstream issues addressed. That way, when surgery is done, it tends to hold. I'm Dr. R.Bennett. For the past 25 years, I've seen patients consent to procedures their bodies didn't truly need, and others avoid operations they should never have been scheduled for in the first place. The long-term data is clear. For many of these conditions, conservative and surgical paths often reach similar outcomes over time. Surgery may get you there quicker in some cases, but when the body is given the right support and conditions, it can often heal too. Give it that opportunity. Your doctor probably won't have time to walk you through all of this in a short appointment. There's no reimbursement code for explaining why you might not need a procedure. If this resonated with you, subscribe to Dr. Bennett and hit like. We're growing toward 1,000 subscribers through honest, practical conversations like this one. Help us get there.